So the goal of today's first session is to discuss efforts to restructure healthcare delivery systems at the state level in order to better address the needs of birthing persons. I have the pleasure to introduce our first speaker of this panel, Dr. Catherine Menard, the Upjohn Distinguished Professor of Obstetrics and Gynecology at the University of North Carolina's School of Medicine.
Well, thank you. On behalf of my many contributing colleagues, I feel honored to have the opportunity to present on the North Carolina Pregnancy Medical Home and highlight opportunities whereby similar models can advance health equity and reduce maternal mortality. To put this in context, I'd like to begin by sharing a little bit about North Carolina and the state's birthing population. I'll then briefly describe the genesis and key components of the North Carolina Pregnancy Medical Home, designed to better serve the needs of the state's birthing population. And I'll close by sharing my thoughts on how such work can advance health equity and improve maternal health at the individual and population level. Next slide, please. North Carolina is about 50,000 square miles, spanning from the Outer Banks to the stunning Blue Ridge and Smoky Mountain, with major metropolitan areas and expansive farmland in between. With a population of about 10 million, the counties depicted on this map as rural are defined as a population density of less than 250 people per square mile. North Carolina has about 120,000 births annually, with 50 to 55% funded by Medicaid. The map depicts the distribution of birth hospitals by delivery volume, illustrating a fair distribution of level 3 and level 4 centers across the state. Next slide, please. Relative to the US, the North Carolina population includes a slightly larger proportion of people of color. In 2019, 35% of birthing people with Medicaid identified as non-Hispanic Black and 23% as Hispanic, with 1% Native American. Approximately 70% of births to Black persons in North Carolina are paid by Medicaid. Next slide. The North Carolina maternal mortality rate and race disparity reported by the CDC is similar to the US as a whole. The rate among those identified as Black is lower than most other states in the Southeast. Because of time and space limitations, I only portray Black and white race on this slide, as this data illustrates the most profound disparities in outcome. Next slide, please. Pregnancy-related deaths are reported by North Carolina's longstanding maternal mortality review process, with rates shown here in 4-year intervals due to small numbers. This illustrates a decline in the Black population maternal mortality rate and an increase in whites, with a marked change in the Black-white ratio over time. The disparities are profound. In 2006 through 2019, similarly, the severe morbidity in the Black-white ratio was 1.7. Next slide, please. In 2019, North Carolina had the 10th highest low birth weight rate in the US and a problem that plagues the southeastern states. In this map, the light colors indicate higher rates. The chart on the right illustrates low birth weights in North Carolina and related preterm birth rates. The birth of a baby weighing less than 5 pounds, 8 ounces is 2 times more likely in Black births compared to white. Native Americans were 1.5 times more likely, and Hispanic rates were similar to that of white population. Next slide. With that context, I'll now turn attention to a description of the North Carolina Pregnancy Medical Home, which we call PMH. In 2011, North Carolina Medicaid partnered with the Community Care of North Carolina, referred to as CCNC, a provider-led entity that with decades of experience building and supporting community-based healthcare delivery systems. The aim of this public-private partnership was to improve the quality of care for pregnant Medicaid beneficiaries, improve birth outcomes, and to improve the quality of care. Working in collaboration with the Department of Public Health, we designed a program that engages maternity care providers in quality improvement efforts and provides community-based care management, focusing services with those at greatest risk. The care management model was inspired in part by previous work done in South Carolina, where a region-based care management intervention was associated with significant reduction in very low birth weight. Next slide. The components of a population-based prenatal care model are indicated here. A network of engaged prenatal care providers, clinical leadership with regionally based teams that offer provider support, clinical practice guidance, standardized risk assessment, a robust informatics system, and importantly, community-based care management. I'll share more detail with each program component. Next slide. An expansive and diverse network of providers helps to ensure access to care. The map depicts the 420 PMH enrolled practices. The purple bubbles depict privately owned or healthcare system-owned community practices that provide the majority of care to the population. The green are community health departments that provide prenatal care. The red are academic OB practices, and family medicine practices are indicated in orange. Mapping like this gives us a sense of where service is and isn't easily accessible by geography. Next slide, please. The structure for the PMH program is combined of 14 regional networks, each with an OB physician champion and nurse coordinator. The OB champions are respected, public health-minded medical community leaders from major academic centers, large health systems, public health departments, and urban and rural OBGYN practices. They work in partnership with an OB nurse coordinator to offer the PMH provider community consistent messages and support related to clinical initiatives and program performance expectations. They share practice level data for use in quality improvement. Most importantly, they listen to the needs and concerns of the local providers and bring feedback to the state level where program and policy changes can be addressed. Next slide. As needs are identified, the clinical leadership collaborate to develop evidence-based clinical pathways with supporting materials and resources for quality improvement. Some of those topics are listed here. Next slide. A standardized risk assessment is completed for each Medicaid beneficiary during their first prenatal visit. The screening tool shown here captures medical, obstetric, and psychosocial factors associated with preterm birth. To a large extent, these factors mirror risk factors associated with maternal morbidity and mortality. Validated screening instruments are used to identify psychosocial risk factors such as tobacco use, food insecurity, housing instability, and you can see those on the right side of the screen. In practice, nearly 80% of women who receive care in a PMH are assessed using the risk screening tool. This data is used to guide prioritization of care management services. And in the initial program design, 12 priority risk factors from this page were identified. Next slide. Next slide, please. CCNC created a robust statewide population-based clinical informatics resource that illustrates the individual and population needs. From risk screening data linked to Medicaid claims to care management data and birth certificate data for outcomes, we derive quarterly metrics to share with PMH practices, county-based pregnancy care management programs, regional networks, and the Medicaid leadership. Measurement of clinical quality reflects program priorities, such as use of the risk screening tool, timeliness of entry to prenatal care, postpartum care, contraceptive choice, tobacco cessation, counseling, and mode of delivery, among the other metrics reported. Next slide. With the data, there's much we can do. Here's an example of the data visualization that's reviewed at the state level and is shared with participating practices. The risk screening bubble chart depicts the expected benchmark of 80% screens, and each bubble represents a PMH practice with the size of the bubble reflecting the number of attributed births. Practices can see how their performance compares to their peers, and the leadership team can identify where to focus resources for greatest impact and improvement. For example, these large bubbles at the right are larger practices, but some are well below the benchmark, and intervention there could make a big difference. Next slide, please. We can also look at, next slide, we can also look at individual metrics that are trended over time and again, available at the state, county, and practice level. This example is the metric of entry into prenatal care during the first trimester, one of several collaborative QI initiatives with which practices have chosen to engage. The practice level data can be tracked over time in a timely manner to evaluate each test of change. Next slide. Another example in the next slide is pregnancy and tenderness, which is asked at the time of the initial risk screen. Since the inception of the program in 2010, various improvement initiatives have contributed to this encouraging trend, indicating a decrease from about 52% to 44%. Providers have engaged in QI work related to the adherence to the postpartum visit with interconception counseling. Care managers help remove barriers to adherence to the postpartum visit. Health benefits, they discuss health benefits of birth spacing, contraceptive choice, and availability of family planning benefits. Policymakers have been responsive to provider concerns with financial barriers about outpatient or inpatient postpartum long-acting reversible contraceptive, for example. Next slide. Importantly, all of this data can be stratified by race ethnicity available in the birth certificate. With a large enough data set, as illustrated in these graphs, of statewide data from 2019, one can identify meaningful differences in trends in race ethnicity. For example, for risk screening rates, which is in the upper left-hand chart, though the Native American population in North Carolina is relatively small, the teal blue tallest bars are quarterly data indicating that risk screening in this subgroup consistently exceeds the benchmark of 80%. I believe this high performance is attributable to the effectiveness of the culturally matched Native American care managers in certain counties in North Carolina. This graph also illustrates the gray bar, which is our Asian and Pacific Islander group, where there is opportunity for improvement. Next slide, please. Through use of vital records, we can also examine some outcomes by Medicaid versus non-Medicaid, and also stratifies by race, as illustrated here for low birth weight rates and cesarean birth rates. Next slide, please. A very important component of the PMH model is community-based pregnancy care management. As mentioned, this is a care coordination model focusing on those at highest risk for preterm birth, as indicated by the PMH risk screening tool. Services are delivered by nurses and social workers employed by local health departments who work in collaboration with the prenatal care providers, most of them embedded in the PMH offices. This clinical public health partnership is designed to ensure optimal communication and an integrated approach to identifying barriers to care and meeting the pregnant person's preferences and needs. Importantly, these care managers are from the community, know the local culture and available resources. Face-to-face encounters are encouraged, and many occur, again, in the provider's office. Next slide. In the initial years of the program, 70% of the population was identified as risk for preterm birth, at high risk for preterm birth. Understandably, providing that many people with care management ran resources rather thin. So CCNC then used the North Carolina data to identify which risk factors were most impactable through care management. That is, which risk factors high intensity care management was associated with a lower rate of preterm birth. This data led to the creation of the Maternal Infant Impactability Score. In developing the scoring system, greater weight was given to those factors for which care management demonstrated benefit in pregnancy outcome. Next slide. The MIS score was divided into 3 strata: high, medium, and low, depicted on this slide. The strata indicated not only risk, but also describes the frequency and type of expected care management contact that is to be provided. The graphic illustrates the validation of the score as effective in identifying those most likely to benefit from care management. Benefit was seen in high and intermediate strata at 5 completed patient-centered tasks shown across the bottom. The low birth weight rate is shown on the vertical axis. Greater benefit was seen with face-to-face versus telephonic contact. This alternative method of focusing care management resources was implemented in 2017, and currently approximately 30% of the pregnant and recently postpartum patient population is receiving care management resources, concentrating those resources in those we feel that may benefit most. Next slide, please. Following implementation of the MIS score strategy, we evaluated its use in practice by examining low birth weight in rates in the highest risk group, and we stratified by race. The bar graph on the left compares outcomes for those that actually received intensive care management in the 2-year period, defined as greater than 5 face-to-face encounters with a care manager, to those who did not receive the intervention. A significantly lower low birth rate was seen in both Black and white subgroups that received intensive care management. The graph on the right depicts outcomes for all women in the high-risk group the year prior, whether they received the intervention or not, compared to all women in the after the implementation of the new stratification, whether they received all of the intervention or not. With this analysis, Black women had a significant reduction in low birth weight rates, but white women did not. And despite this intervention, importantly, Black women delivered low birth weight infants at higher rates than white women. Understanding how programs such as the North Carolina Pregnancy Medical Home can influence maternal and infant outcomes, particularly health disparities, can influence state-based policy change. Next slide, please. I'll now take a few moments to reflect on 10 years of experience with the program and highlight the features that I believe have the greatest potential to advance maternal health, equity, and reduce maternal mortality. I believe that a standardized risk screening assessment for every pregnant patient, regardless of color, preferred language, education, or socioeconomic status, can minimize bias and lead to more equitable and appropriate identification of need with connection to local resources and appropriate care plan. Second, practice level process and outcome data stratified by race and ethnicity can reveal specific and actionable differences, stimulate detailed gap analyses, and enable data-informed rapid cycle quality improvement. Third, a locally designed, patient-centered, team-based model supports the unique needs, culture, and values of the individual within her community. Having care managers who are community members, often race concordant, as part of the care team can promote a deeper understanding of the pregnant person's needs, preferences, and barriers to care. The patient may experience a greater sense of trust when they feel part of a well-integrated team. Fourth, provider engagement and accountability is promoted through sharing of data and collaborative learning with the provider community. North Carolina, like many states, has done a good job with state quality collaborative improvement efforts that focus on inpatient care. The implementation of consistent protocols within hospitals for management of conditions such as obstetric hemorrhage and treatment of severe hypertension have been shown to advance equity through, though important disparities persist. In obstetrics, it's unusual to find effective infrastructure for broad-scale quality improvement in the community and outpatient setting. The leading cause of pregnancy-related death in Black birthing people is cardiovascular disease. This cannot be addressed by hospital-based quality improvement efforts. A structure for implementation at scale in the outpatient setting is needed. Fifth, practice support for program implementation and quality improvement can make the "wouldn't it be great if" a reality. The PMH OB nurse coordinators have a relationship with practices in their region and with the embedded care managers. They're trusted. This provides an infrastructure for communication and implementation. For example, in the early days of the COVID-19 pandemic, when home blood pressure monitors became available through Medicaid, there were many steps between a policy change and actually getting blood pressure cuffs in the hands of women and ensuring that they knew how to use them properly. When important initiatives become available to advance equity, such as the CDC Hear Her campaign or implicit bias training that's available through the March of Dimes, meaningful and timely change requires strategy and infrastructure for broad-scale implementation. And sixth, and finally, at the system level, we can measure and monitor what we care about if we have data systems and a structure about related to equitable access, program performance, and quality. For example, mapping first trimester entry into prenatal care in North Carolina revealed that the greatest need was not in rural areas, but in the 2 largest cities, where there's a high concentration of providers, but many that limited their acceptance of Medicaid. Identifying drivers and solutions to this problem is just one example of an issue that can be best addressed through an established and trusted partnership with the community, the providers, public health, and those making policy. Such is the North Carolina Pregnancy Medical Home. Next slide. On behalf of my colleagues, I'm grateful for the opportunity to share our learnings. I would like to acknowledge the incredibly committed community care of North Carolina team, especially Tom Roth, our leader, Kate Berrien and Kim DeBerry, our brilliant and creative nurse program managers, Carlos Jackson, the leadership behind all things analytic, and most of all, the team of regionally based OB champions, nurse coordinators, and community case care managers and providers, as all improvement happens locally. Our contact information is provided, and we welcome inquiries. Thank you.